Delp, whose topic is up there for all of us to see. She's the professor of biomedical sciences, College of Medicine at Florida State University. And she got her BS from Rockhurst University in Kansas City, Missouri, and went on to do her PhD at University of Missouri. And her research focuses mainly on cardiovascular adaptations to aging and exercise training. And very specifically, her work tends to look at adaptations of the microcirculation in the heart and skeletal muscle that occurs with aging, and particularly how exercise training can reverse microvascular dysfunction that tends to occur with advanced age. She's the author of more than 100 published papers, and we're really pleased to have her talk about something that ISL had a small impact on, in the sense of a small grant that she received. So Judy, please go ahead. Sorry about the delay.
Oh, that's okay. All right, so everyone can see my screen?
Yep.
Okay. All right. So as Neil said, I've had a long-standing interest in the effects of more aerobic exercise training and how important that is in terms of having anti-aging effects, in particular in the microcirculation. So interestingly, some years ago, it's been much longer now than I sort of would like to think about, but there was a young Ph.D. student from Japan who was actually working on his doctorate in physical therapy, and he contacted me and he said, you know, I'm getting some very interesting results from doing some passive muscle stretching in patients who are pretty much immobilized. Some of them had had a myocardial infarction. Some of them were patients who had been hospitalized because they had pretty severe heart failure. So he was, as a physical therapist, was going and doing passive muscle stretching in them. He said, it really seems to be improving their endothelial function. And he said, I have read some of your papers and I've really seen that you can look at the microcirculation. So I would really like to come and work with you for a while and see if I can't learn how to apply some of this and learn some of this, maybe using an animal model like you do, to see what happens if we use muscle stretching in an animal model. He first came and said, can we use an immobilized animal model? And I said, well, I have a lot of data that says the endothelium is pretty dysfunctional in old rats. And I have a lot of experience with old rats. So maybe we should try this in an old rat model. So really, that's what we did. So this is Kazuki Hota. And he came over and we kind of copied something from a paper where they had used a splinting model to try and combat some changes in skeletal muscle in animals that were undergoing hind limb suspension or microgravity. So in that model, their hind limbs aren't allowed to really bear weight, and they get some pretty rapid changes in muscle and in the microcirculation. So he said, can we try this? Can we put this splint on that will basically dorsiflex the ankle of these rats? And if that happens, when that happens, all of these muscles that are on the backside of the tibial bone get stretched. So while the splint is on, they get stretched. So the plantaris, the soleus, also not shown here, some stretch in the gastrocnemius, but the rat is different than the human, so not so much stretch there, but definitely in the plantaris, the soleus, the flexor digitorum longus, and the flexor hallucis longus muscle. So these are all muscles that start up here or here, and then they insert down here. So when you change the orientation of that ankle, they get stretched. On the other hand, these anterior muscles, the tibialis anterior and the extensor digitorum longus, don't stretch. So we took these rats, we said, let's try 4 weeks, 30 minutes a day, 5 days a week, and we're going to put this splint on and we're going to cause stretching. So when we tried that, what we actually found, well, one of the first things we did was say, well, acutely, when we put this splint on, what happens? And indeed, what we found was that compared to the non-stretch, so in the rat, we were able to do this with microspheres, and we were able to do this and say, okay, we can stretch one leg in the rat and not the other leg. So their non-stretch legs served as a control. When we did that and we compared during actually having that splint on, what we found was that in those muscles that were stretched, the soleus, the plantaris, the flexor hallucis longus, and the flexor digitorum longus, blood flow went down. In the tibialis anterior and the extensor digitorum longus, blood flow didn't change with that stretch. We also did some stuff to look like immediately after we released the stretch, was there a change? In general, blood flow did go up as soon as we released the stretch, but we didn't necessarily see differences just in terms of at the 1 minute mark when we were able to measure this blood flow, there weren't differences. So from this, we kind of thought, wow, this is at least part of the stimulus. Part of what's happening here is we are actually reducing blood flow or causing ischemia, and that is probably part of the signal. And then, so we went on from there. We did 4 weeks of stretching daily for 5 days a week. And we said, what happens then if we put these animals on a treadmill, have them walk on the treadmill? Is there, in fact, after stretching, any effect in these old animals on the blood flow going to these muscles? And we did, in fact, find that at rest, there really wasn't a big effect. But during exercise, there was, in fact, a significantly higher blood flow in those same muscles that got stretched every day. So the soleus, the plantaris, the flexor hallucis longus, and the flexor digitorum longus. So when we compared in the same animal between stretched and non-stretched, and one of the things that's important in this model about being able to do this is these blood flow things could be relative to central changes like your heart changing or heart rate being different. But in these animals, that's not an issue. Blood pressure and heart rate are the same between the stretched and the non-stretched legs. So we were pretty sure that something was happening within these muscles that was contributing to this increased blood flow. So one of the next things that Kaz did was to, let's see, hold on. There we go. Was to actually look at endothelium dependent dilation. So he had already done some of this kind of work in large arteries in people. So we actually took small vessels, resistance sized arterioles out of the muscle, the soleus muscle of these rats, and compared stretched and non-stretched. We also compared some sham controls. And we found that indeed there was increase. So this is acetylcholine. It's a known endothelium dependent dilator. So it's known that if you put this on blood vessels through a mechanism that is dependent upon the endothelium, which is the innermost layer of the blood vessel, if you remove that inner layer, this acetylcholine mechanism will really be non-existent almost. So when we tested the responsiveness or the relaxation in response to these increasing doses of acetylcholine, what we did in fact find was that these are the responses. This is a pretty poor dilation to acetylcholine, and we had already shown that in old animals, this is pretty dysfunctional. But we showed that with stretching, we could actually markedly improve that response. Now, one thing we have not shown yet is if we did this in an animal that's completely normally functioning, for example, a young animal, would we get this kind of response? And it's probably less likely that we would get this if it was in someone who had either a human being who had really good function or an animal that already has great function. So, sorry. So, whoa, what are the next? Sorry, I certainly hit that too many times. Okay. Let's see. So one of the other things we did was to look at some of the things that might be changing at the cellular level in these blood vessels from the stretched limb and compare them to the non-stretched limb. So what you're actually looking at here are cross sections of one of those resistance arterioles from the skeletal muscle. And this is staining for something called endothelial nitric oxide synthase. Nitric oxide is known to be one of the most important endothelium dependent vasodilators that's produced endogenously. On the other hand, there is superoxide dismutase, which is known to actually also be important in terms of maintaining that vasodilation that we just saw because this is actually scavenges superoxide. And if you have too much superoxide, it can compete with this nitric oxide and reduce responsiveness to nitric oxide. So we looked at these two mechanisms. We didn't find a difference with the superoxide dismutase, but we did indeed find that expression of endothelial nitric oxide synthase was increased in the arterioles from the stretched limb. So we looked at HIF-1 alpha. That's something that's kind of a master regulator of responses to hypoxia and or ischemia. We did indeed find that HIF-1 alpha expression was in fact increased. We also found that vascular endothelium-derived growth factor was increased. Now, nNOS, which is sort of the neuronal isoform of nitric oxide synthase, that was not increased. But these two mechanisms do appear to be contributing, and again, sort of makes us think some of this at least is being triggered by that ischemia that we're inducing during the actual time when the stretch is on. So the next thing that we did was we had this really what we felt was pretty complete and comprehensive study completed in a preclinical model. So the next thing we said was, could we make this work in patients? We started some of this while we were, while I was still at UF, but then I came over here to FSU and Kaz joined me back again. He came back as a postdoc for 2 years. He got some funding from the Japanese Heart Association. So he came back and he had this human experience. I didn't have any, but he really was the driver of this study. And along with a colleague who has left, Dr. Batchelor over at Southern Medical Group was also incredibly instrumental in helping us do this study. So at Dr. Batchelor's suggestion, because again, my experience was somewhat limited, he said we should do a crossover design. If we want to do this in a relatively small number of patients, and Kaz had somewhat of a limited time span that he could be here. So Dr. Batchelor suggested that we do this kind of a design where we recruited patients. Some of them came in and stretched and then did not stretch. So this was 4 weeks of stretching, 4 weeks of not stretching, and some other patients came in, did not stretch for 4 weeks. All of them went through 3 sessions, a first session, second session, and third session. And then, but some of the patients did not stretch, came back in for their second session, and then started their 4 weeks of stretching. So these are the patient characteristics for the whole group. We started with 15. We managed to get 13 of those completely through the whole protocol. They were on average about 70 years old. We had somewhat of a, I guess, representation that would, we did what we could, but we definitely had most of them were older white subjects. There was a pretty even distribution between males and females. We split them evenly between which arm of this study they were in. And overall, they had probably somewhat of an elevated BMI, not completely. But the main thing also was we decided to do this in patients who had peripheral arterial disease. So they all had an ankle brachial index of less than 0.9. That's one of the main things that is actually a main diagnostic criterion for saying someone has ABI. They can also be diagnosed with ABI if they, with peripheral arterial disease if they have just significant claudication or pain when they're walking. But this is probably clinically the main thing. And like I said, at first we thought about doing this. And when I first thought about this still at University of Florida, we were going to do this in just older, healthy patients. But we really thought in the end, this was potentially a patient population who was most likely to really potentially benefit from this stretching mechanism, because we think one of the reasons that it's as effective in the patient population, the PAD patients as it is because they have become relatively immobile. They're not moving around as much because they have so much pain when they walk. So I, as an exercise physiologist, would never say, hey, you should just do stretching instead of exercise. If you can walk, I am always going to be a proponent of keep moving, keep walking. It's probably one of the best anti-aging things in terms of your cardiovascular system you can do. But in these patients who have really become somewhat limited in their mobility, we thought this might really be a target population that would really benefit from this. And this is just to show you in our first study, we just bought an off-the-shelf device called the Healwell plantar fasciitis night splint. And some people do actually use this for plantar fasciitis, which is pain and some inflammation that occurs on the bottom of your foot. But our thinking was this would be a way to easily get these patients to sort of mimic that same thing that we've done in the rats, hold a prolonged stretch, static stretch for 30 minutes a day. So we gave them these Healwell night splints. Kaz, with his background in physical therapy, simply really taught them, wear it like this, set the straps here. And he really just measured and tried to put them at 15 degrees of dorsiflexion. If they could, if their ankle could sustain that, that's sort of where he set them. He also sort of worked with them in terms of, let me know when you really feel some significant stretch, but it's not so much stretch that you can't tolerate it. So we kind of worked with individual patients and tried to target a level of dorsiflexion, but we also really worked in terms of what seemed to be effectively stretching those muscles at a level that they could maintain for 30 minutes a day. This is just showing what Kaz did to measure endothelial function. He actually did flow-mediated dilation in the popliteal artery, which is the main artery that goes down to all of your calf muscles. And this is just showing you, this is where he placed the ultrasound probe. So it was really lucky for me that he had this experience and that he was able to really make this happen in this setting and with these patients. And of course, Dr. Batchelor was really, really helpful also in terms of helping us find and recruit those patients. So this is what we found in terms of the flow-mediated dilation. It did indeed increase with the stretching, which is a little bit what we were expecting given the big increase we'd seen in ACH-induced dilation in the animal model. So what these are showing you is in these patients, this is flow-mediated dilation just as a percent. This is normalized flow-mediated dilation. But regardless of whether you express it this way or you express it normalized, this is to normalize for shear stress and the size of the artery. In both cases, we actually had a significant, so this shows you the individual data. Some patients really increased. A few really didn't show us much of a change, but the majority did in fact increase, and it was a significant increase, whether we express it as just a percent or normalized flow-mediated dilation. This is nitroglycerin-induced dilation. So this is a way of assessing endothelium-independent dilation, and that did not change with 4 weeks of stretching. It's possible that even this would potentially change if we did more subjects and didn't have quite so much variability. But for right now, we really have as we've continued on, really focused on this idea that the cell type that's probably really being affected within the arteries themselves are the endothelial cells. So the other thing that we wanted to see was whether the walking function, because these patients have pain when they walk, and it's probably part of what's keeping them and contributing to the continual decline in their overall function, is the fact that it hurts when they walk. So a very standard measure in these patients is to use what's called the 6-minute walk test. So the patients are simply on a 30-meter, very well-defined kind of measured out distance. They're asked to just walk as far as they can until they either have to rest or until there's enough pain that they have to give themselves a rest because of the pain, or just continuously walk for the entire 6 minutes. So the distances that are measured are the continuous walking distance, or how far do they go before they stop, the total walking distance, how far can they go in the entire 6-minute period, and then of course, symptom-free or pain-free walking. And what we found was that indeed, total walking distance did increase and continuous walking distance increased. So it really looked as if we're improving endothelial function and we are improving the walking function of these patients. symptom-free walking distance appears to be something that in patients is much more variable. I think that's because some patients probably kind of just are not as aware of, or they don't report the same when they really feel some pain. So the one other thing that we did was we looked at this and we said, is there any relationship between that endothelial function and the walking distance? And we did indeed find that there was a significant relationship in these patients between their normalized FMD or flow-mediated dilation and their total walking distance. And then finally, because we had this crossover design, one thing that we wanted to think about was and it was a small number of patients, but even in the 7 patients who first, who walked and then did not, who stretched and then did not stretch, we might be able to evaluate a washout period and see whether these changes were really well sustained. And the interesting thing that we found, and which I was not completely surprised about with my background in studying the endothelium, was that flow-mediated dilation indeed improved over the 4 weeks of stretching, but then it went back, or during the washout period, it also declined significantly. And that did not completely surprise me. The turnover in the endothelium is pretty rapid. It's actually a fairly adaptable cell. You can expose somebody to, or in animal models, just even a slight exposure to hypoxia changes lots of things in the endothelium. The same with even just a few bouts of exercise has been shown to change the endothelium. So it's this very adaptable, very kind of labile cell type, if you want to think about it that way. On the other hand, though, which was very encouraging to me, was that the continuous walking distance actually remained improved even after 4 weeks of the washout period. So what that says to me is that while this effect on the endothelium might not be so sustained, there appears to be something perhaps that we're changing within the muscle that is actually improving the health of the muscle itself. And these people are still able to walk further, even after 4 weeks of not stretching. So what we have been doing since then is to, one, come up with sort of a modified device that we think is better suited to these patients. And so some of the money for this actually came from a collaborative, some money that we got from both I'm sorry, I'm blanking on the name of the program, but it's the program here that's through the Office of Commercialization to develop something. And then also we had some collaboration with the Mayo Clinic that was also to follow up on some of this. But we have come up with sort of our version of this splinting device that we think is really patient friendly. So the idea here is there are still these straps and they are placed and they are set, but we try to set them in a way that makes it easier for the patient to put it on by having the degree of dorsiflexion not be quite so great just based on where the straps are set. So the idea is the straps are set, we tell the patients how to use it, and then they put their foot in while they're in a seated position and their foot is on the floor, and they put their foot in here and they can really snug their ankle back in and their the back of their foot back in here, get the clips on. Then they put their leg out in front of them, which I'll show you in a minute. That's actually quite important to get the maximum amount of stretch. Once they get their leg extended in front of them and they're in a comfortable position where they can read or watch TV, and they have one of these on both legs, so they have both legs out in front of them, then the final amount of dorsiflexion is actually created by a pneumatic cushion that's underneath their foot. And that is actually inflated by this bulb device. And we make this long enough so that this is up near their knee or their thigh and they can reach it from their seated position. So they are able to sit in a chair with their foot on the floor, put the device on, but then they're able to make the final adjustment with their legs in front of them. So this next slide shows that this is just sort of a schematic that I actually put in for the patent that we applied for, to show that this is the anatomical position we want them in. We want them seated upright. We don't want them laying down. And we want them to have their knees, both knees, fully extended so that they maximize that stretch, especially for us, different than the rat, is a lot of the stretch is occurring in the gastrocnemius muscle, which actually its origins are above the knees. So the amount of stretch is very different if your knees are flexed versus completely extended. So we hope that we are creating a way where they can, at home, put the device on relatively easily with their foot, with their knee bent, their foot on the floor. And then they can put both legs out in front of them, have both devices on, and then use this inflation to set the final degree of dorsiflexion. And so therefore, they get the maximal amount of stretch that we want them to have, and they can get themselves all positioned without having to hopefully have any help from another person or another caregiver. So what we are doing now, and what we are doing somewhat with the Mayo, and also what the ISL planning grant is allowing us to do, is to go beyond measuring just walking and endothelial function and actually start to measure some muscle metabolism and some microcirculation within the skeletal muscle itself. So we are doing this with a device called near infrared that works through near infrared spectroscopy, and it's placed on the calf. And what that allows us to do is to measure the ratio of oxygenated to, if you want, deoxygenated. So we look at the saturation of hemoglobin, and that is somewhat of a surrogate for what the muscle oxygenation is. So essentially what that allows us to do, and again, all of this has been done really with the help of a new postdoc in the lab, Jacob Caldwell, and then he has also been working closely with Jake Martinson. So the two of them have really made all of this possible. And they are, so what you see here is, this is a test that we do just to get an idea of the overall muscle metabolism, and then reperfusion, or the reperfusion or the microvascular perfusion capacity. So what you're seeing here is muscle oxygen saturation at baseline, and then we put a cuff on and we inflate that cuff, so that pretty much occludes all flow. And we watch and we look at this slope as the flow to the muscle is occluded. We do that for 5 minutes and then we release it. So this is the reperfusion. So this slope shows you, is analogous to showing you what is happening in terms of resting muscle metabolism, because you are not allowing the muscle to get any new blood flow. And so this is telling you how quickly the muscle is metabolizing the oxygen, if you will, that's already been brought to it, that slope. This slope then says, when we release the cuff, how quickly does the oxygenation come back to where it was at baseline? So this slope tells us how quickly the muscle becomes reperfused. So when we have tested this now in 5 subjects, and we've looked at both that slope that tells us something about resting muscle metabolism, and then also that reperfusion slope that tells us about the microvascular reperfusion, we have indeed found that here also there is a significant effect of the stretching. So in this case, this is pre and post in the same subject. We are actually also over at the Mayo Clinic doing placebo controls. So we are trying to send people home without having them use that pneumatic cushion device. And we are trying to set that, they are putting the splints on every day, but we hope that they are putting them on and not really getting that much muscle stretch while they're on. So we're doing placebo controls there. And then the ISL has also given us money to try and do some of this also in patients that are either control patients or patients that we are giving, in addition to the stretching, we are giving them creatine as a supplement. So really trying to start to get at that question of, could we use this in conjunction with, say, a reasonable kind of supplement to also see what that would happen in terms of augmenting some of these things like muscle metabolism or reperfusion. But these are Ph.D. patients, so this is pre and post, and there is a significant, that downward slope is actually significantly greater after stretching. And that's an indication that there's actually increased resting muscle metabolism, or an increased ability to kind of extract oxygen under those resting conditions and utilize the oxygen that's there. Indeed, also, we found that microvascular reperfusion is significantly, well, close to significantly increased on both of these, but these are only 5 subjects. So we really think that as we continue on, and we are planning on doing, we're at the Mayo, we're supposed to do 40 subjects, 20 that are actually stretching and 20 that are placebo stretched. And then the Institute for Successful Longevity has given us money to also do these kinds of measurements in these patients. And I think we are hoping to get at least 20 patients through when we can get back to having these older patients come in. This is muscle oxygen saturation then during the 6-minute walk test. So we also put this NIRS device on the muscle and have them go do the 6-minute walk test. And this is what that might look like. And this is an actual tracing from a patient. So this is baseline saturation. Then this is what you see what happens. There's this initial increase right as you start walking, but then it starts to drop off. And then of course it comes back up. So eventually we will be able to also look at this slope or this reperfusion slope potentially even after just exercise. Right now, what we have really focused on looking at is the saturation at minute 1, at minute 2 during the 6-minute walk test. And indeed, even here, even with just an N of 5, we actually have already reached significance. So there is a significantly, the change, this is actually a measure of the change at, let me go back. So we looked at the change from here to here at minute 1 and minute 2, pre and then post. So there is actually a significantly greater change at minute 1 and at minute 2. And that is an indication that potentially the muscle is actually extracting or utilizing more oxygen during the walking test, which is an indication that we are indeed changing the metabolic properties of that muscle by stretching for 4 weeks. And this potentially says that that muscle is healthier and better able to use the oxygen that's being delivered to it. So last but not least, the thing that we are also really trying to do is to validate our NIRS based on what we get in the MRI. And so this is just to show you data from, not from a Ph.D. patient, just from a normal subject, to show you these are the data that we would get with NIRS. These are the data that we get with BOLD or oxygenation in the blood in the magnet. And we are hoping to get to the point where we have enough subjects that we can really validate our NIRS measurement with the BOLD measurements that we get in the magnet. So again, this is during occlusion. So this is going to look somewhat like what I already showed you, where you have that rapid decrease in saturation during that 5-minute time period. We get somewhat the same effect in just this one subject when we do that with the in the magnet. The thing about the magnet is you really have to be very careful about where you analyze these data within the whole muscle. So you can get a lot of data from the MRI, and how you analyze it is really going to change potentially somewhat how this looks. So we're still working on that, but we think we really are getting a much better handle on how to do these things. And the other thing that we really want to show in the MRI is that we are really getting a significant change in oxygenation while the splint is on. We are doing this with the NIRS as well. I didn't show you those data, and we are trying to do them in the magnet as well to really get a better idea of, I showed you in the rats that blood flow, there was this ischemia that was created during acute splinting. So rather than measuring blood flow, we are trying to measure oxygenation. And we're trying to measure really also oxygenation, or BOLD. That's what is measured with BOLD imaging in the magnet, to get an idea and to really validate that when we have this device on, we are indeed creating some ischemia. We are probably also creating some stretch, and we have not yet some actual physical mechanical stretch, but we haven't really started to analyze that yet. But that might be something that we think about in the future. And the other thing that I wanted to point out here is that when during the stretch, whether you're looking at the nears or whether we're looking at this, what's going on in the MRI, there does also appear to be this phenomenon, and we've seen it a number of times, where this is before the device is on, and then this is immediately after putting the device on. And even though they're having the device on for 10 minutes, there seems to be this drop in blood flow or this relative change in saturation that suggests that oxygenation is decreasing, but then it's starting to come back up. So this makes us think, and we've seen something somewhat similar with the MRI, this makes us wonder whether it wouldn't be reasonable to think about having patients do, say, 3 10-minute bouts to really maximize that signal that happens. And this is something that physiologically is done fairly often. It's called ischemic preconditioning. And it's been noted for a long time that if you do several bouts of just brief bouts of ischemia, this has a protective effect, for example, in the blood vessels in the heart. And sometimes they actually do it before a transplant because there is some evidence that it sort of conditions the blood vessels and makes them a little more reactive. And that's typically done with several bouts of, say, 5 minutes. So one thing we have thought about is, would it be more effective to have patients do several 5-minute or 10-minute bouts as opposed to a 30-minute continuous bout of stretching? So as I said, we have to really thank the Institute for Successful Longevity, especially for the things that we are trying to continue to do, which is especially the supplementation with the creatine and everything that we're doing in the MRI. And then Jake Martinson is hoping to also do some stretching plus supervised exercise in these patients. And then along with Lynn Panton, especially, we are really hoping to do some follow-up where one of the things we really hope is that this improves function, that these people start to be a little bit more functional after they do this stretching, and that maybe gets them moving a little bit more. So we would really like to do some follow-up for physical activity with accelerometers. We would like to bring them back. We would like to, at the end of stretching, and then maybe bring them back and see if we can do some measures of functionality in Lynn's lab and some quality of life measurements. And we have even thought about them, of course, trying to follow them for almost a year and see if there's any change in their acute cardiovascular events that are reported. And then Colm Connolly and I have even talked about, if they do start exercising more, would we actually also be able to use the MRI to start to get some idea, and anything else to get some idea of whether it's potentially improving cognitive function. Not necessarily the stretching directly. I think that's going to be a pretty localized effect. But if the stretching gets these people moving more, then will their cognitive function increase? So with that, again, I need to remember to thank the medical school for some money they've given us here at Florida State University. The RAT work was all funded by National Institutes of Health. And of course, now the Institute for Successful Longevity is helping us keep this work going. And these are all the people that worked very hard on this study, especially Kazuki Hota, Jacob Caldwell, and Jake Martinson, but really all of these people. Mauricio Buchanan is the clinical coordinator over at the Mayo Clinic, and Wayne Batchelor was certainly very helpful. Dr. Hakam is the individual who is the vascular surgeon who we're now working with over at the Mayo Clinic. John Katapodis is still at Southern Medical Group. And of course, Lynn has been very helpful throughout this whole thing as far as giving me coaching and helping me with everything human that I don't necessarily have as much familiarity with. These are all folks who helped with the animal studies, and these are students or postdocs who helped with the animal studies. I think I haven't forgotten anybody. But it takes, obviously it takes a huge lab to get any of this work done, and especially when you're talking about combined animal and patient studies, it takes an enormous input of work from a lot of people. So If
Thank
anybody
you.
has any questions, I'd be,
Yeah, we've got one. A lot of us have been suffering apparently poor internet connections, I guess.
oh no.
We've got the equivalent of rolling blackouts in internet going on this afternoon. Let me read Alice Pomodoro's question for you.
Okay.
Said she was typing due to unstable internet connection and audio, although I see her back, so maybe. But anyway, she notes it's very interesting that she has two questions. One of them is monitoring renal function in a creatinine study. The second, or the further in the comment, what are the symptoms reported from the patients? And then she also comments she's a little surprised they can tolerate ischemia for as long as you have them undergoing it. And then what's the correlation with standard pulse on the finger would also be interesting for some activities. Oxygen saturation, however, variably affected by other issues and comorbidities, which may not be related. For instance, COPD. In other words, some of these patients multimorbid for additional conditions, which might also be playing a role in things like your measures like oxygen saturation.
Yeah,
Or
so
at least a couple of questions there.
yeah, so let me see if I can, okay, I might have to go through those backwards. So if we think about that question, first of all, with comorbidities, there is no doubt that some of these patients, for example, the NIRS measurements are very much affected by just the amount of fat tissue that's potentially present. And there are potentially obese patients who we won't be able to get that NIRS measurement in them. It only goes, Jacob could tell me exactly how deep that measurement goes. So there are definitely limitations there. I think that one of the things that I thought from even Kaz's study is that one of the reasons why there is more variability in what they think of as pain-free walking is because one of the things that we try to assess in them as they're doing this that I didn't report is also just the rating of perceived exertion. And so I think there are some patients who probably have some other comorbidities like COPD. We don't necessarily exclude them for that. We exclude them from almost all kinds of major cardiovascular disease other than PAD. But it's very possible, like if they're in heart failure, they're not in the study, but it is definitely very possible that they have some other things that are contributing to, especially some of the measurements in the 6-minute walk test, and especially the pain-free walking. I think one of the reasons that there's so much variability there is because there are some patients who actually probably stop and rest, not just because of their the claudication pain, but because they just feel so tired, especially if they have something like COPD going on. So there's no doubt that we can't completely exclude all of those things. And I really hope that eventually we do this in a very large number of patients so that we can start to maybe get enough patients that we can look at some of those covariants and sort some of the data that way. Now I'm trying to think of what some of the other, the question, we thought about thinking about trying to do something like toe oxygenation or something with their finger, even just also as another way of sort of saying, does it correlate well with what we're getting with the NIRS measurement? And I think that's not a bad idea. We haven't done it yet, but it would be possible to say then, do we have a second measure, especially in the patients where we're afraid that the NIRS measurement is not going to be as accurate because of the amount of body fat that they have. And now I can't remember the other, the ischemia. So one of the things that we've thought about since seeing some of the data that what the NIRS data is showing us while the splint is on is that there does seem to be some return of blood flow. So there seems to be this stronger initial ischemia. And then I don't know whether blood flow is redirecting to other muscles or there's some redistribution of flow in there, but it doesn't stay really low. The stretch continues, but there does seem to be some reduction in the actual ischemia over that prolonged stretch. So that's why I've been almost thinking, would we get a greater effect or something if we actually sort of did just 3 5-minute bouts or something like that. And I think that that's one of the reasons why they can tolerate it, because, and we do try and set it at a level where they tell us for sure, okay, I can feel that, but it's not so painful that I can't keep it on. And trying to think of.
The other was monitoring renal function in the
Oh,
creatinine
yeah,
study.
that's something that we definitely, only from the literature, but we did a lot of looking in the literature to make sure that it's really safe to give these. And most of the data in the literature say that that's the one case where maybe you need to be careful. And we definitely wouldn't let anybody in who has any evidence of any kind of renal disease and give them creatinine. So that's an exclusion factor for that. But we think for the most part in just older patients, based on the literature, especially at the dose we're giving them, that the creatine supplement is actually quite safe, even in older subjects, and that it won't affect their kidney function. But that's based on the literature. We're not measuring any kind of clearance or anything in them.
Great, thank you. Other questions? People can either type them if they have uncertain internet connectivity, or we're happy to unmute you and raise a hand or whatever, and let you ask that way.
Thank you, Judy. I think this is really fascinating because the mobility issue is so huge for so many people. And you just did a fabulous job of answering a ton of questions in a really short period of time.
I do. The one person, I have to tell you, Alice, that the one person who's not up here, who I have to say thank you to you for putting me in touch with Dan Kalin. He has been, now that things have changed in terms of our ability to kind of interact with TMH, he has been fabulous. He has been so helpful to us. And I have enjoyed my conversations with him so much from a vascular viewpoint. So I really have to thank you for that. He has really, really been, I feel bad that I don't have his name up there because I should.
I mean, he's really, this is his, you know, what he does all day, every day as a vascular surgeon. So he's very knowledgeable. I'm really glad that's working out.
Yeah. So he has a lot of patients who can't be in this study, but he also has a lot of patients who I think, you know, he's helped us identify who are good candidates for this. So there are 4 stages in terms of how they rate patients with peripheral arterial disease. And we really only want stages 1 and 2. People who definitely have predictable claudication, but they're at no risk for critical limb ischemia or anything beyond that, because we simply think that potentially at that point, the muscle has already deteriorated enough that this is probably not going to help those folks. But early on, we really hope that we're doing something to, and we do hope also, I actually wrote a very large NIH grant that didn't do terribly well, really focused on trying to use this and work with a bunch of people over at who are very knowledgeable about mitochondrial biology and who have already really set up things with vascular surgeons over at UF to take muscle biopsies from patients. And even though it was still focused predominantly on doing that in PAD patients, the idea was, can we get enough data about what's happening vascular in terms of vascular function, in terms of metabolic function, also working with people over there who do energetics in the magnet, to really say, could this be something that could be utilized by any patient who has severely decreased mobility, whether it's after a hip fracture, anything that keeps somebody from being able to walk? Could this potentially be even a short-term, solution for those folks? So unfortunately, NIH didn't see it as so promising, but we'll keep trying.
You have to be persistent.
Right.
Okay, well, we've run to 1 o'clock. I'll let you go a little longer because of our glitch right at the beginning. For those who can afford to stay on just a little bit longer. But thank you so much, Judy. Thank our audience here today, and we'll let this go on for at least another few minutes in case there are some follow-up questions. But others who have to leave, please feel free to go. Judy, I had a question as well, because you're looking at the splint as a way to go after very specific muscle groups.
Hmm.
So I guess the way I'm understanding it.
Right.
And I'm wondering about, you've got kind of a passive stretch type situation. Have you thought of putting in I mean, obviously there aren't enough people at this point in time to even run the study, let alone get another control group. But the idea of getting a control group that does a separate set of active stretches as opposed to the passive stretch.
Yeah, I think that would be pretty interesting. And I will say, Jake Martinson, Lynn, the student working with Lynn Panton, I'm going to be very interested to see what he finds, for example, if you, and I don't know if he's going to run an exercise group that's some sort of controlled exercise, but I think, that's an interesting point, because you wonder how much of this is actually a component of what happens when people just go through normal range of motion during a bout of exercise, and how much of it's, and I do think also that there is probably some component of this actually a mechanical component. And so that's something that we really haven't investigated yet, and there's definitely, there's an investigator out at the VA and I think he's Department of Exercise Science as well in Salt Lake City, Russ Richardson, and he has done a lot of work with passive muscle stretching, but not like this, not static. He's done a lot of it, and he actually has made a case for using moving muscle passively through the range of motion, and the vascular response to that, he finds, is a very good predictor of the vascular health in those patients, and actually is a very good sort of biomarker for endothelial dysfunction, for some other things. So, and like I said, they're using passive stretching that's being done by someone through the entire range of motion. So the patient isn't doing any active stretching, but they're not doing static stretching the way we are. So I think that's a very good question. It's not something we've approached yet, but I do think it's a very good question, because it can't be as simple as it's just this prolonged ischemia that's causing these adaptations. I'm sure there's more to it than that. And
what I was wondering is the necessity to get that kind of reafference, the feedback from the fact that you're actually carrying out motion. And I just haven't got any sense at all as to whether or not that might trigger other gene expression than just the pure mechanical stretch activity.
right,
So,
I think that it probably would. And like I said, I think that even a little bit what we're doing is mimicking a small component. But when you think about, for example, regular or even walking exercise, all of these things are happening. There's a point where you're really stretching the muscle, you're taking it through the range of motion, but there's also active contraction in the muscle that's happening at the same time. You're doing things to stimulate the Golgi tendons at the end, where you connect to the bone. And that's the other thing, is we've seen some interesting effects even in bone with this stretching. And that says, and we've seen differences in the bone in terms of the proximal portion of the tibia bone versus the distal portion of the tibial bone. And only the proximal portion of the tibial bone is seeing a change in blood flow during the stretch. And yet we see some changes in the bone in the distal portion. So that says that's more of a strain that's being placed on the bone. And probably all of those things are happening in muscle, and in this case in bone, and during a bout of exercise, and especially in terms of expression of different things and the other thing that I didn't tell you is, at least in the rat model, we get some hypertrophy of those muscles when they're stretched. So that says a lot of things that are being turned on besides the vascular effects.
Yeah, it's a pretty complex system that you're stimulating here in one respect.
Yeah.
Just on the mechanical side. Yeah.
Yeah. So all good questions.
I appreciate that. Any last minute questions? Otherwise, we're going to let Judy go. Thank you very much, Judy, for a really interesting presentation. I hope you have better luck with being able to recruit over the next few months.
I do too.
This is a really, really difficult time for the entire research community, and I know you'll have so much more power when you get up into the 10, 20 range than
Right.
you do with obviously just with your first handful
Yeah.
of patients.
Well, thanks everybody for listening, and thanks for the great questions.